These patients are sicker often than they can appear on paper. How can I do the least amount of added work to my already busy schedule and more accurately reflect who these patients are, improve efficiency, maximize quality, and minimize complications or errors, and then let the data speak for itself?
Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. Today is a structural heart innovations episode. We are discussing how 10 minutes can save you thousands, while at the same time capturing appropriate acuity in heart failure patients to ensure they get the care they need. Today's guest is Dr. Manu Uberoi from Portland, Oregon. Dr. Uberoi is Director of Structural Heart Interventions at Kaiser Permanente. He is a coronary and structural interventional cardiologist who completed his medical residency at Stanford and cardiology fellowships at Cedars-Sinai. He is also a fellow of the American College of Cardiology. So welcome to the podcast, Dr. Uberoi.
Thank you. It's an honor to be here.
Well, it's great to talk with you today. So lots to say about Dr. Uberoi's extensive experience and expertise, of course, in his field. So I truly encourage everyone to take some time, read his full bio in the episode notes. But let's get started. So the first question that we do like to ask all Heart Talk guests: why did you decide to get into healthcare? You've had such a big impact on your topic. So did you ever have that aha moment when you first got started, or even before you were thinking about getting into this?
I don't think it was an aha moment per se. I had a series of events that I think led me to the field of medicine. So I grew up playing a ton of sports in the 80s. So, back then it was all about blood and guts and skeletons and things like that, kind of this interest of many young kids, but I was fascinated by it. And playing sports, I noticed that there was a lot to ability and accomplishments that some people seem to be able to get, and while some may not. So that first actually led me to pursuing a master's degree in physiology because I liked the exercise component, and I did my research on exercising populations, young and aging. But that kind of lacked the personal touch, the interpersonal relationships and connections, which then led me to medicine specifically. And I was most fascinated by the cardiovascular system. So initially what started for a love for sports cardiology, once I actually got to fellowship, I was introduced to interventional cardiology. And essentially from the first time I saw the real life heartbeat to heartbeat hemodynamic shifts and the consequences of our actions in real time, I was hooked. And that led me to structural interventional cardiology because I was fortunate enough to train at a very high volume center by some phenomenal mentors. And so here we are.
Wow. Sounds like education was your key to really, truly getting where you needed to be.
Yeah, I've been lucky to have the access and the privilege to train with some of the best, and education really has afforded me the opportunity to do some pretty cool things.
All right, kids, make sure you stay in school. You never know where you're going, right? All right. So a 2019 research letter published by the Journal of American Medical Association says symptomatic severe aortic stenosis is associated with high mortality rates, in fact, up to 50% at 1 year. And the prevalence will likely increase as the population ages. So it's essential to capture appropriate patient acuity in heart failure patients and get them diagnosed before it's too late. So can you think of a time when this has been the case for one of your patients?
Oh, absolutely. I mean, we see this almost with every patient where patients come in with severe aortic valve stenosis. They can start quite mildly symptomatic or asymptomatic and very quickly just tip over the edge, as I say, and they get a lot worse, a lot faster. The rate of decline isn't often is not linear. It's often kind of this exponential drop off where one day they're doing quite well and independent and relatively active, to within the matter of a few weeks can be relatively incapacitated, sitting on their sofa watching TV all day because they can't do much beyond walk into the bathroom and back. Waiting seems to be the biggest issue. Delays for whatever reason, whether that's patient willingness, whether that's the limitations with how busy medicine is right now and low support staff, or lack of either hospital resources, care provider resources, et cetera. We're seeing this a lot. Unfortunately, we're actually seeing, I would say, this more often than we used to see it in the past, where the degradation of quality of life seems to be more pronounced, I would say, in the last few years. And perhaps that's a result of resistance to seeking medical care during the COVID pandemic, when it was really touch and go, where we didn't know the direction of COVID itself. And then the consequence of a workforce shortage, I think, has really accentuated the problem.
Yeah, and some of those we don't see necessarily getting better anytime soon. You and your TAVR team at Kaiser have led successful EHR documentation strategies for capturing patient acuity. Can you explain your process for creating templates, or what you call dot phrases?
Yeah, so it all starts with understanding who the patients are. So kind of going back to that last question about understanding acuity, understanding how urgent is urgent. These patients largely are considered quote unquote elective. I don't know about you, but I don't know anybody who electively seeks heart surgery or heart interventions. These patients are sicker often than they can appear on paper. And so in understanding how quickly we need to act, and then how to speak with hospital administration to prioritize perhaps your cases over some of the more purely elective cases, orthopedic, hips and knees and things like that, that more improve quality of life, not necessarily extend life or have a number needed to treat like TAVR does. It's essential to understand who the patients are. So in an effort to impress upon everybody the importance and the high needs of these structural heart patients, we took a pretty deep dive into understanding how can I do the least amount of added work to my already busy schedule, and more accurately reflect who these patients are. And with that, tell them a data-driven story instead of, hey guys, take my word for it, these guys are sick. I can say, this is the mortality if we wait. This is the cost to the hospital if they come in an acute heart failure exacerbation, versus allowing us to do this in a more urgent or semi-elective process. So writing dot phrases has been a key for achieving this. Now, a dot phrase, for those of you who are not on an Epic system, is a templated note, where if you write dot period or dot, the character period, and then whatever you end up calling that note, you have a templated note. This was motivated by, first of all, years and years of using Epic, because I grew up in a EHR era. So thinking about the philosophy of a templated encounter, I'm able to capture many more details that I might forget in the process, because you have 100 things going on in clinic. Patients, we can talk about random tangents or related, unrelated, but if I'm not capturing the important markers for acuity, then I'm doing a disservice. And this is loosely based off of Atul Gawande's whole thing about, checklist manifesto. If you can follow a checklist, a standard operating procedure, you're going to improve efficiency, maximize quality, and minimize complications or errors. So by creating dot phrases, I've been able to very quickly make sure I get all the quality data I need for our TVT registries or ACC registries, if we're talking about PCI. But I have all the data I need to make sure that my coders and billers can capture these patients at the highest level, and then let the data speak for itself.
That makes perfect sense. And I think, just even thinking of templates and other phases of our lives, that does allow us to make sure that we get the most information, the most pertinent information down in a timely fashion. So, we're literally talking about, 10 minutes up front. It obviously saves you time, and crucially, you maintain quality while getting the credit for the actual work that you're performing, as you explained. As we know, the higher acuity DRG 266 is reimbursed at about $10,000 higher than DRG 267. So can you explain why the notion that lower risk patients aren't as sick is not necessarily true when you touched on that a minute ago, and then kind of walk us through what this $10,000 difference means to your bottom line?
Absolutely. So, there's a lot of scrutiny on structural heart procedures, right? Because valves are expensive, hardware, upfront capital expenses expensive. And many programs struggle with the financial justifications, even though patients love it, data is resoundingly positive. But when it comes to logistics of medicine, unfortunately, we do have to think about finances. So making sure that you're getting credit for the work that you're actually doing, I think, is imperative. And so, the phrase lower risk patients aren't as sick. A patient can be low risk on paper in terms of problem list or, past medical history. But in order to capture the acute presentation or what they are looking like on the day of procedure, there are certain things that you can track or certain elements that you can include in your note that would almost assure that you will appropriately capture a 266 DRG qualification instead of a 267. And so, in other words, you're getting the money you are due or being able to bill for the money you are due accurately. You're not, quote unquote, leaving money on the table. Mm-hmm. And that was how we got into this. As we mentioned before, I was at Cedars, and we were a very high volume center, even back in 2015, 2016. And the volume has exponentially increased, it seems, at that institution. By not writing our notes properly, we were leaving a lot of money on the table. So I think very astutely, my mentor said, why don't you tackle this problem, work with who you need to work with in order to make sure that we are showing people how sick they are. We are showing the institution and the world how important TAVRs can be, and how much of a game changer this procedure can translate to. I mean, it's a huge game changing procedure. So just with a little bit of time, I was able to work with our resources and figure out that it just came down to wording, how as fellows were writing the notes. And so an optimization of the words made it so that we would capture to the true high acuity. For example, we were measuring, and we do measure hemodynamics in every patient. Now that might seem to add 2-3 minutes to your procedure time, but that 2 or 3 minutes can translate to accurately reflecting that they're acute on chronic diastolic heart failure, as evidenced by the LVEDPs. And there was an excellent podcast on this program just a few weeks ago with Dr. Tarani talking about the experience in the Emory system in Piedmont, that's saying one of their systems was doing EDP measurements while the other wasn't, and now they have adopted that widely. I mean, this is a perfect example of just how they document captures reflects the true severity of the patient at that time. So just by virtue of that, or discussing that they are getting active titrations in their diuretics, etc., those can make sure that you do accurately capture your higher DRG, your higher reimbursing DRG.
So taking the time to create these EHR templates sounds like a no-brainer. I mean, obviously it's just smart business, and it's better for the patient. So still, you are the poster child for what we've been talking about. But can you speak to some of the reasons why other physicians might be hesitant to write dot phrases? Intimidation, maybe with technology, or as we all know, we all have a little bit of ego. Does that sometimes get in the way of this?
Oh, for sure. I think it's a bunch of things, and all of those things probably do play a role. I think the biggest barrier is either not understanding, not knowing how easy it is. Therefore, it seems like a daunting task. I don't want to take this on. I'm not a technology guy. I don't want to take this on. Or I can dictate a note in 5 minutes while you're over there messing around on your computer. And that's, old practices are kind of hard to break. But I can assure you that doing this is going to be more efficient. I can assure you that doing this actually gives you some of your power back. Some of the things that we lose in spending all this time being a slave to medical records and admin and all these things, we end up getting some of that autonomy back because we can control how these notes are written. There's still a place for it where if you wanted to dictate on top of your note, you could do the subjective things or the other things of interest to you. You can still write a dot phrase template to make sure you capture the acuity of the patient. A dot phrase takes a few minutes once you get used to doing it. So now, having done this for a fair number of years, I can write a note and a dot phrase in the matter of a few minutes. The first time it might take a little bit more time. Again, it's mostly because you got to navigate through the system you're not used to navigating through, creating shortcuts in your Epic system that can allow you to do these in the matter of a few minutes. But I can write a note, have my orders in, and go out and see the next patient in the time it takes to finish one dictation with better quality. Because again, I might forget X, Y, or Z, but if that's templated in my note, I can't sign that note without addressing that issue that I know would capture the higher acuity DRG. So there's a lot of things. Fear, I would say, is probably the biggest driver, fear of change. Yeah, maybe a little bit of ego, but the fear of the technology is probably the biggest thing. And I can tell you, I'm not a tech guy. Even though I grew up in the Bay Area in the era of tech, I'm not really the tech guy. But if you can click a few buttons, someone can onboard you how to do that, then it becomes easy for even the person who's, pecking at the keyboard. You can still knock these out and get great notes in the matter of minutes.
Yeah, sounds like just with a little bit of practice and a little time on the front end, you really do start to see those benefits.
Exactly.
All right. So this is a great place to take a quick pause for a quick message. And when we come back, we are going to talk about how to do this. Hopefully you feel like this may be something that you're interested in learning more about. And that's exactly what we'll do after a quick message for our Heart Talk listeners. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back. So we have been talking big picture about why patient acuity is essential, how to leverage EHR templates and innovative strategies to overcome the barriers. So now let's dive just a little bit deeper. Dr. Uberoi, for those who are ready to start creating their dot phrases, what 4 steps should they take first?
Well, I think the first step is understanding what the TVT registry even looks for. So if you're unfamiliar, if you're a busy operator that doesn't have time to get into the nuts and bolts of what the registry is even asking for, honestly, step 1 is just getting your hands on a registry form and looking to see where you could do better. In other words, if you're dictating your notes in a certain way, and a lot of us go into autopilot when you're dictating, you almost don't even hear yourself, and you're going through what you would normally dictate in a note, compare that mental script to what's on this piece of paper. Are you saying any of these things that is required from this form? If you don't even know where to start to modify your mental script, then I would start by getting a TVT registry form, figuring out what data you actually need to capture acuity. Step 2 probably is something that will sound foreign maybe, but taking a 30-minute coffee meeting with your biller or coder. I didn't even know what they looked like, where they sat, who they were. But it turns out, if you were to talk to your billers and coders, they can, with a pretty high accuracy, tell you which doctors do this well and this poorly. So starting by just the simple conversation with these people who do the coding can really enlighten you to where you can bolster your notes or dictation. And it also just actually makes the team work more efficiently. They're more inclined to reach out to you to say, hey, I noticed this trend. Maybe we could add this. And after I established my meeting with my coder, when I first set this up, it created this two-way communication, which, again, it just really greased the wheels in terms of making sure that I could add whatever their suggestions were to my dot phrase, because that takes 2 seconds to modify. But then every patient moving forward would have that capture. And there's a process in doing that. It's, again, to go back to the specifics of Epic, pressing your F2 button takes you to all these checklisted things that you can't sign the note unless you've addressed those things. It's easy to pop in those types of high return on investment details where you would capture that acuity. Step 3, I would say now you're starting to get to the more the intimidating part. This is the, how do I even approach my Epic system or Cerner or whatever? You can even do this in the VA system in a different way. It's a little bit different, but you can still get it done. So you have to identify who can help you write this. If you're not tech savvy, talk to the person in your division that might be, or you can reach out to your IT person and they can educate you in the matter of a few minutes, create a few shortcuts on your Epic desktop, and then really empower you not only to do that at that point, but then prospectively moving forward, you can do that on every patient for everything. I have this personal thing. If I have to type something more than like 5 times, I'll just make a dot phrase out of it. So Chad's VASC score, bang, it'll show up. Or, indicate ACCH recommended guidelines for observation of thoracic aneurysms, bang, I put that in, it's there. All these things, if I have to type it out multiple times, that's inefficient. So I might as well dot phrase it and make my work way more streamlined.
Yeah, makes sense.
The final thing, and if you don't even know where to start with that, who your IT person is, you can often start even talking to your valve rep. They have a lot of insight and resources, or your local IT person if you're in a bigger hospital system. Most people have a super user or something like that where they can guide you in the right direction. And then, I would say the fourth step is more the ongoing optimization and refinement. If you know how you like your notes to sound, or you want to make sure that, in the future, if you change your practice, like you use this wire instead of that wire or whatever, you can modify your note to reflect your ongoing evolution in your practice. Every subsequent note, addendum or modifications will just take seconds to minutes. So you really save yourself a ton of time over the course of a year or years by just doing this small amount of work once. And I tell you, like I said, I'm not an IT guy. I can't properly set up my Wi-Fi in my house without a little bit of struggle and consideration. But this is super easy, and even I can do it. So I'm telling you, it can be done.
Those are great points. So what does your note actually look like?
So I have 3 notes. My first note is an intake note on my initial consultation. This is when you get your patient from your referring cardiologist. You have the standard things reflected, history of present illness, your review of systems. I have these tabulated things that I can F2 through. I could go through. This is the checklist that if I don't sign these, the note can't be signed, or if I don't address these problems, the note can't be signed. For example, in order for me to understand prognosis, I always have these 3 questions: angina, syncope or presyncope, heart failure. And that is a throwback to the Grunwald idea of how long these patients are going to live with symptomatic severe AS. Moving down the list, you have problem lists and past medical history. Now, this is critical. This is just a dot phrase. You write, it will automatically incorporate from your medical record their problem lists and their past medical history, which very often in and of themselves qualify you for some of the higher risk DRG or major comorbidities. Prior stroke, recent GI bleed, things like that will pull from your problem list and automatically be in your note, so that when your coder is going back to look at your note, coders aren't allowed to interpret. They can only mark what is there. So even though you might in your more subjective section allude to some of these things, if your word choice is not explicitly what they are sanctioned to check off, you're not getting credit for it. So and consequently the quality is going to be suffering, because you're not accurately reflecting who these patients are. So your problem list you can incorporate that. And then it goes, your physical, etc., vital signs, and pertinent labs. Again, pertinent labs. A lot of people don't like to congest their note with a lot of labs that might seem irrelevant. However, if a person is anemic and they're chronically anemic, or their labs reflected an acute drop in their blood or an acute rise in their creatinine, those types of things, again, will capture major comorbidities. I didn't do any additional work, but we have automatically made sure that the coder can capture these patients. And then you go down to your assessment plan, etc. Those things, the subjective section at the top and your assessment plan at the bottom, those are the places where I empower the physicians who have a preference for dictation to use their dictation for those segments, because you can still say the subjective part in the way that you normally like to dictate your notes, and then just populate that section of your note. So your quality from your perspective isn't different, because you still get the well thought out assessment and plan, but you've captured these things that are being extracted from the note electronically, or your medical record electronically, and put into your note. So it's a win-win. That's my intake note. Then I go to my procedure note when I see them next. Again, a lot of these things are auto-populated with those dot phrases. They just show up into the note. They make sure that they capture the acuity. I do hemodynamics, so always it's going to have EDPs listed. I'm going to say the NYHA class, the essential frailty, or the frailties test, all these things that we capture, they're all going to show up in the note, because I have written the note to automatically pull those elements into it. And that's that idea of the checklist manifesto. I don't have to remember on each and every patient that I'm doing the 100 elements or whatever that are in the registry, because the note is designed in a way to pull the majority of that information for me. All I have to do is write things that are case specific, where I modify my note.
Yeah, sounds pretty cool. So let's move forward. How do your dot phrases help engage ER physicians and prevent hospital readmissions?
Yeah, so what I looked at is, once we started getting some of our TVT registry data back, I started to recognize our institutions or my program's strengths and weaknesses. So in looking at the weaknesses in a closed system like a Kaiser system, we're going to have very high capture for things like readmissions or blood transfusions or things like that. And being in a closed system, an integrated system like this, it allows the next provider to see what you did. So on that note, the procedure note, and on the next, my third note, my discharge summary, my follow-up and discharge summary, the headers have very clear in bolded red lettering: if this patient presents to the emergency room, urgent care, another care facility, etc., call these numbers in this order, right? If it's during the day, they call my nurse. If it's during the nighttime, they call me or the interventional cardiologist on call. Doing this simple step allows you to get some of the control back, where you can help direct whether that person is going to get readmitted. If it's an appropriate admission, great. A lot of the time, we can just help our colleagues with a little bit of guidance and potentially prevent a readmission, which is both great for the patient as well as for our resource poor hospitals right now. Again, specifics for those notes in terms of capturing quality and major comorbidities or higher, lower DRGs. It's not anything that I've done anything extra for. I wrote that note once a year ago, and right. Every note moving forward is making sure it's still capturing every one of these patients to this highest quality. Plus, it creates a standard. So in the future, if I ever have a question about what did I do for that person or why did I do that, I can quickly just refer to my standardized note and know exactly what the thought process was. So it really does make it easier, and it is extremely efficient and ensures maximal quality of care. Not to mention, you're also earning the highest level of revenue that you should have earned in the first place without necessarily doing any extra work.
Exactly. And in time, it gets easier because now you've created something that you can reuse. Let me ask you, because I even think in television, when we do things, the more people you have on the team and the buy-in, it helps things to be, successful. So, if you're listening to this and you think, oh my gosh, that sounds so complicated, when you go to your coder or your biller, or you go to your IT staff for this help, did they kind of get excited about it as well, knowing that they're doing something kind of bigger than maybe what they're doing on a day-to-day?
Oh, absolutely. You nailed it. I mean, they are a part of they are a part of the team, but you make them feel like a part of the team. You empower them. Every study is going to show you that if people have ownership and kind of this two-way communication, that your outcomes are going to be far superior to if you don't do those things. So you end up doing a lot more than just capturing your data. Fortifying those relationships are going to make your whole clinic life easier and all your future billing stuff easier, because now they know you as a person, not just that doc. And so I absolutely think there are numerous benefits to taking that extra step.
Yeah, sounds pretty cool. So if, your peers who have listened to all this and they still say, whoa, this is just too big for me, maybe still a little hesitant, what would you tell them?
I felt that way too. It really is a lot smaller a task than it sounds like, because it sounds like we're getting all fancy with words like dot phrases and F2 and DRG. I honestly I didn't even know what a DRG was, but it takes truly a very much less time than you would think to really optimize your program, maximize your efficiency. That's going to translate to higher output. It's going to, no offense to the admins, it's going to maybe get them off your back if they're looking at your money and your bottom line, because you're getting what you should be getting in the first place. Also, the data speaks for itself. So if you're in a community or a city where there's a bunch of competing programs, if you're better at coding, you're higher acuity. When people look at TV registry data, you can then with confidence say, look, our program is this good. We are the best in the area. We are the whatever. We are top 10%, whatever in our area, with data to back those claims up, because that data is reported and it's identifiable. And so just by making these tweaks and modifications here, you can really make sure you're getting all the credit, whether that's reputation credit, whether that's financial credits, or whether that's kind of this stock or credit with your relationships with admin to give you the resources you need. In every way, it really seems to be beneficial with very little input going in. And it really is the matter of a few minutes, not hours and days. And it's not that complex.
Yeah, 10 minutes. That's how we started. That's all.
Yeah. No, I think that 10 minutes will save you hours over the course of the year, and even more hours of heartache and stress if you're not getting what is due to you. If you're not accurately reflecting how sick the patients you are, everybody's getting less quality at that point.
All right. Well, what a wonderful conversation. And we're walking into the new year with dot phrase. Let that be our buzzword maybe for 2023. Dr. Manu Uberoi, thank you so much for sharing your time and your expertise today. I know you're so busy on MedAxiom HeartTalk. We enjoyed this conversation.
Thank you. It was a pleasure, and I'm happy to be here. Thank you for having me.
Well, that is it for this episode. If you liked it, please tell your colleagues and let them know they can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. If you would like to send us a note directly or even suggest a topic, email us at hearttalk@medaxiom.com. Thanks so much for listening.